Next, we have From Death to Life by Dr. Ahikam.
Good morning, everyone present here. Today, I'll be presenting on behalf of Medicine 3. Presenting Mrs. E, a 33-year-old lady. She was a booked-in patient, G2A1, presenting at 20 plus 6 weeks of gestation. She came to us with history of fever for 1 day and orthopnea for 2 days. She was apparently well till 2 days ago when she had a sudden onset breathing difficulty, which was not associated with any chest pain or palpitations. This breathing difficulty was also marked by her difficulty to not be able to lie down. Orthopnea was present. And this was a worsening of her breathing difficulty from a NYHA class 2 to class 4. And along with this, she had a fever which was low grade for 1 day without chills or rigor. There was a running nose and a sore throat associated with the fever. She is a known case of rheumatic heart disease with a severe mitral valve, mitral stenosis, and was on tab torsemide 10 mg twice daily, tab metoprolol XL 25 mg once daily, and on penicillin prophylaxis. Moving on to the examination, patient pulse rate was 130 beats per minute. Her BP was 100 by 70. She was febrile with 100.3 degrees fever with the respiratory rate of 24 per minute. She was pale and had pedal edema, did not have any icterus, clubbing, cyanosis, or generalized lymphadenopathy. Her CVS examination showed the apex being localized to the left fifth intercostal space, just medial to the mid-clavicular line. The S1 was loud with normal second heart sound heard. Snap was present and a mid-diastolic murmur was present. Just was heard in the apex, heard best with the bell of the stethoscope with a pre-systolic accentuation. She was also noted to have bilateral wheeze and creps at arrival, but otherwise there was vesicular breath sounds heard bilaterally. And abdomen, her fundo was palpable to 1 hand width below the just below the umbilicus, and CNS examination did not reveal any focal neurological deficits. So this is a pretty straightforward case where the patient with the mitral stenosis has come with pulmonary edema and with a probable concurrent upper respiratory tract infection. The main thing I want to highlight is what happened to the patient after she was admitted. So patient was admitted with severe breathing difficulty and was admitted to the ICU, where she was tubed by the end of the day due to increased work of breathing. And she was not able to be weaned off the ventilator, and hence they proceeded with a tracheostomy on 11th of July. And because there was a fixed outflow obstruction as far as the severe mitral stenosis was concerned, patient underwent a balloon mitral valvuloplasty after she had undergone tracheostomy. Post the balloon mitral valvuloplasty, patient was improving significantly and was eventually extubated from the ventilator, and she was shifted to the ward. And on 12th of August, she had contractions and shifted to the labor room. And 2 days later, while in the labor room, she had sudden onset tachypnea, breathing difficulty, and where she was gasping, and she had a cardiorespiratory arrest. Probable causes, maybe a tube block would have been there, which might have been slightly delayed in picking it up. So my main thing that I would like to stress in this clinical meeting today is cardiac arrest in pregnancy. So cardiac arrest in pregnancy, how is it different? So any patient who's pregnant for 20 weeks or less, the same ACLS protocol is followed. However, a patient who's pregnant 20 weeks and above, the new element that we need to consider is, apart from circulation, airway, and breathing, the delivery is the other important aspect that needs to be considered. So what are some salient features? I'll come to the algorithm at the end. I'd like to mention some of the few salient features which are slightly different from the normal ACLS protocol that we have for a patient with cardiac arrest. So chest compressions in pregnancy, everything is same in the sense that we need to use a firm backbone so that all the compressions that are delivered is effectively reaching the patient. The patient needs to be placed supine, and the hand should be in the center of the chest, and hard and fast compressions to be given with a minimum of 100 cycles per 100 chest compressions per minute, and depth need to be given, and there should be very short pause, should be less than 10 seconds, and minimal interruptions of the CPR should be there. and chest recoil should be complete. The main point to be considered here, there is a continuous manual left uterine displacement. So, what is the point of this uterine displacement? So, there is an ioto cable compression that happens because of the gravid uterus that is sitting on both the IVC and the aorta. The IVC being compressed, it will prevent the venous return from occurring. So, thereby, historically, a tilt has been suggested whether patient a Cardiff wedge or if the patient is on a operating table where there's a 15 to 30% tilt is maintained for the patient. So that the uterus is slightly displaced to the left, which allows the venous return to happen. However, it is noted, this is as per the 2015 AHA guidelines, more than 30% of tilt, they've noted that the mannequin either slipped from that plane and the CPR was difficult because when CPR is being given from 90 degrees to the floor and the patient is at an inclined angle, the effective compression is not there. And also the position tilts to the left. So how this manual lateral uterine displacement is done is the uterus is cupped and lifted up and pushed leftward off the maternal vessels. So as is shown in the picture, it can either be done from a person of the resuscitating team who can be from the left as is in the picture below or from the right as is shown in the picture above. A point to note here is, however, it has been noted that when the patient was placed at an inclined plane of 15 degrees, that there was a lesser chance of hypotension in a non-arrest patient. Then coming to the airway. Airway, the challenges that can be faced in a pregnant patient is that there can be laryngeal edema, which makes it a bit more difficult to intubate the patient. There is an increased risk of aspiration because of the lax esophageal lower esophageal sphincter and the gravid uterus causing mechanical reflux. This means that the best way to secure an airway for a pregnant patient is to a cuffed ET tube to be placed. So, what are the practice changes that we need to adopt? Usually, we take a size 7 or 7.5 for female patients. However, when it comes to pregnant patients, advisable to use a slightly smaller size tube, 6 to 7, and not more than 2 attempts must be done. And the rescue airway, which is suppose we try for 2 attempts and we're not able to secure the airway, supraglottic airway with the esophageal drain should be placed so that the suctioning can be done in order to prevent any aspiration in case the patient vomits or throws up. The main different feature that is seen in the ACLS protocol for a pregnant patient in cardiac arrest is the perimortem cesarean delivery. So the need for the perimortem cesarean delivery is, though the left uterine displacement to some way offloads the pressure on the IVC and the aorta, it is not as much as effective as the perimortem cesarean delivery, where the fetus is delivered along with the placenta. And this facilitates the resuscitation and it also decreases the risk of permanent neurological damage from anoxia. This is holds good for the mother as well as the baby. So this is primarily done in order to save the mother. So even if it's just 24 weeks of gestation, anytime about 20 weeks, they have to go ahead and do this. So how is it done in practical? The patient should not be transported wherever the patient is. Like if it's in the ward, then and there, the perimortem cesarean delivery should be done. It should be done within 5 minutes of CPR. So the guideline puts it that it should be started by the 4th minute if ROSC is not obtained. And either the vertical incision or the fan and seal incision is acceptable as per the obstetrician's preference. So just to summarize everything that I've just mentioned, so the BLS and the ACLS is done as per it started as per a routine protocol where high quality CPR is given. Defibrillation, as indicated, the same dose for shocking is given. And if there is difficulty to place the pads because of engorged breast, the AED can be placed, one anteriorly, one posteriorly can be placed. If it's placed in the normal way, the left AED can be placed lateral to the breast. And after the maternal cardiac arrest team is assembled, so the maternal interventions that are performed are airway management, administering 100% oxygen, and to avoid excessive ventilation. IV cannula should be placed above the diaphragm. That means if a central line is being placed, femoral will not be the best option. So you'll have to place something above the diaphragm. And then we continue the BLS, ACLS, high quality CPR is given, defibrillation when indicated, and other ACLS interventions such as epinephrine and amiodarone. Interventions where continuous manual lateral uterine displacement is given. This is preferred to the patient being placed on a tilt as per the 2015 recommendations by AJ. And the fetal monitors are to be detached to hinder from any difficulty in performing CPR and prepare for perimortem cesarean delivery. And cesarean delivery, perimortem cesarean delivery is to be done if no ROSC is obtained in 5 minutes of initiating CPR. So this is back to our patient. What happened is they in the labor room, the inner tube was removed and manual ambu bag was done. After one round of CPR, there was no ROSC obtained, so they proceeded to do a perimortem cesarean delivery right in the LR, the high risk labor room. CPR was continued, ROSC was obtained, and patient was put back on the ventilator. And currently, she's in REM-ICU with GCs of 10T. These are my references.
Thank you, Ahikam.
Yes.
What is the cost for the second arrest?
This currently, the exact reason is not known, but it sounds like a tube lock, which could have been the patient was on tracheostomy, and there was a sudden onset.
Yeah. Conscious. She's bleeding on her own.
Prior to that, yes.
So, tracheostomy, tubal block will be extremely unusual. Second question: she's 33-year-old. She's known to have high vital cirrhosis.
That was also discovered just during her second pregnancy, which is in May. She was discovered to have tight mitral stenosis.
And she came for routine. And
she had breathlessness on exertion. So that time she was
first pregnancy. After
first pregnancy, she had an abortion. She did not have symptoms at that time.
And when did she first come for her ambulance check? First time for herself or only when she was now?
She had come in May, so that time she'd have been in her first trimester. That time when the mitral stenosis was picked up. Yes, 0.9.
Come back from 14 weeks for the ANC when the first echo was done. She was admitted with us at around 16 weeks when she had a viral upper respiratory tract infection. The plan at that point in time was to do the balloon mitral valve as soon as possible. She went to cardio at 18 weeks. They said come back at 20 between 20. But she developed this lower respiratory tract infection in the meantime, and then she's been with us since. In a span of 2 weeks between 18 and 20, when we wanted to do the procedure, she got sick again.
The recommendation is to do the procedure in the second trimester.
So, second trimester, sir. They're most comfortable doing it between 20 and 24. But we were trying to push for as early as possible because of the severity of the stenosis. She went to the OPD. They said come back in 2 weeks, but within that span of that 2 weeks, she got sick again. When time all this happened, how hard was the pregnancy and how?
She was 30 plus 2 by the time.
Babies are
As far as I know, baby was.
very bad. The thing is, her dates and the scan dates are not really matching up. So if you look at her dates, she's sick. If we take it from her last period, then it's about 28. If you take it according to the scan, then it's about 30, 31, 32. But the baby is not doing very, very well. I have to check. I'm not exactly sure how the baby.
The initial one was the baby was tubed and was in
baby was on the
NICU. So.
She didn't present for anything to check up till.
Not to us, sir. She went outside, got an echo, and then came here. What is the socioeconomic status of this patient? They're from
Chad patient. Kanimbari.
last case